The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD Warriors. We are gathered here today for the next episode of TMD Demystified. I am Tony Urbanic, and today the topic of discussion and the title, which is a little odd, which I will look forward to explaining and then over the next few minutes, is tennis elbow and TMD. Now, if you are new to this series, you're going to look at me as a viewer and say, what the heck is he talking about? What does tennis elbow have to do with TMD? What this actually is a deep dive into something I've discussed several times before on different episodes, but I don't think I have emphasized it adequately or explained it adequately. I'll take responsibility, either emphasized or explained it properly or adequately. Because I think the viewers who view these episodes, and there are increasing number of viewers, especially doctors who are actually in our network of providers, do not fully comprehend or understand the value and the depth of this concept of the relationship between these two diseases, which are well known and universally described as TMD, TMJ, and tennis elbow. Therefore, I'm going to explain this a little more carefully, hopefully taking a little different tact on it. Those watching may understand quite a bit. But the concept of temporomandibular joint pain and symptoms and where it comes from and how it occurs has been not poorly understood, but not understood to my investigation for all of my career, going back almost now 50 years. What I discovered wasn't as much having to do with some device that looks like a retainer and fits in the roof of the mouth. What I really discovered, although the history of how this was discovered and all that stuff, that's on another episodes. What I really discovered and worked out was the relationship of inflammation and how that inflammation can create all these disparate symptoms, better known as the symptoms related or the symptoms associated with TMD. And again, for the umpteenth time, those symptoms, and there are a few others, like a good example, I had a patient yesterday, my day seeing patients is on Monday, yesterday. Among the other symptoms she had was pain behind the eye. And that probably actually, I need to sit down with my anatomy text again and go through why pain behind the eye and the ocular muscles associated with temporomandibular joint can take place. All right, I don't want to get too off purpose. The relationship of inflammation causing all these symptoms, the usual and customary symptoms of, and well-known, well-accepted, headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain or tightness, arm, hand, finger tingling and numbness, and various kinds of locking. Those are the well-accepted symptoms of TMD. You notice I did not say migraine. Bad headaches, bad TMD headaches. Yes, migraines. We don't fix migraines. In fact, frankly, I am suspicious, and maybe with the help of others, through time, we can actually show that there's no such thing as a migraine headache, because the migraine headache papers and the studies on migraines well admit they don't know what causes migraines. We do know what causes bad headaches that are misdiagnosed as migraines all the time. We know what causes that, which is inflammation within the temporomandibular joint, cause bad headaches. And the patients and the doctors misdiagnose it as migraines. That is not the topic of today. The topic of today is tennis elbow and TMD. All right. So what I actually discovered, what I worked out once I found out that unloading the temporomandibular joint decreases inflammation, and that makes all the symptoms go away. I had to figure out, well, why does decreasing inflammation make the symptoms go away, or why does increasing inflammation within this joint or joints bilaterally create those symptoms? Well, that was the aha moment. It really was the aha moment when I realized that, number one, these joints are like any other joints in the body. I've commented on that multiple times. That is what led dentistry astray, totally astray, 180 degrees in the wrong direction, when all of us in dental school, and I assume almost everybody who watches these episodes went to dental school, we were all taught that this is a very complicated joint, and you have to be a very complicated person to understand it. And it's so complicated, we probably never will understand it fully, because we're dentists and we just don't understand various variations of that. But we all came out of dental school thinking that this is a complicated problem in a complicated joint. That is not true. These joints operate like any other joint in the body, physiologically, anatomically, neurologically. Certainly they look different, they have different aspects, but they operate like any joint in the body. And when I realized that, and simultaneously realized what I had been exposed to or taught by my orthopedic colleagues in my training, in my medical training at Vanderbilt, and they used the example as they taught me, tennis elbow. Well, all right, so when I realized the tennis elbow was exactly what was going on with TMD, there really isn't any difference in the physiologic response, neurologic response. Again, I've talked about this before, but we're taking a little deeper dive today. Hopefully I can emphasize it, explain it carefully, thoroughly, emphatically. I'm well known for being emphatic. So that you really understand this, so that when you're questioned by a patient or a colleague, or you just you need to understand it yourself. And when you are certain about this, once you as the doctor, certainty level goes up that you really know what you're talking about, then you can explain it to others and you can help. Because you can't help if you're not certain about what you're doing. If you're not certain as a surgeon, if you're not certain on how to do surgery, believe me, you can't help anybody. And that's why surgeons are trained to be certain. In any case, you have to be certain about what you're doing here. If you can't explain it, if you don't understand it, how can you help anybody else understand it? Because you're going to be asked. Tremendous skepticism out there that somebody claims to have a solution to TMD problems. All right, so let's just jump into this very carefully and slowly, if I will, and talk about tennis elbow. Tennis elbow is a well-documented, thoroughly understood, look it up for yourself, concept within orthopedic surgery. Generically or generally, it is called lateral epicondylitis. Lateral epicondylitis. Let me get this. I won't take my shirt off, but this, well, do this one. This is the epicondyle. Lateral, medial, lateral, epicondyle of the elbow. Right there, lateral epicondyle. And that lateral epicondyle is an attachment for multiple muscles of the forearm that create motion with the wrist and the hand and even the fingers to some point. Extension, primarily extension. And most of the muscles of the forearm are attached to and around the epicondyle of the humerus, lateral epicondyle. And that is where the inflammation resides. That's where the inflammation resides or centers in tennis elbow. An orthopedic surgeon walk in a room and says, hey, my elbow hurts. First thing he's going to do is he's going to walk over to you and he's going to push on the lateral epicondyle. And if it hurts, he's going to know that that is inflamed. It hurts because it's inflamed. The odd thing about tennis elbow, though, is that most people don't complain about where it hurts right there. They complain because excuse me for waving in front of you, it hurts and has burning sensation and muscle tightness. Burning, by the way, is muscle tightness. That's what muscles feel like if you work out. That's muscles, when you work out enough, they feel like they're burning. They get tight. They feel like they're burning. As we talked about before, the actual pain comes where the muscles are attached to the bone. And when the muscles tighten up and where it's attached to the bone is where the nociceptors are, and they trigger the painful signals. In any case, tennis elbow is more related with forearm tightness and burning and pain, which is generated by inflammation at the lateral epicondyle. Lateral epicondyle is inflamed, and it generates discomfort and pain in these muscles of the forearm. That is a really good description based on scientific papers and the general description of tennis elbow in the literature. Look it up for yourself. Now, this joint operates like these joints, believe it or not. These joints are not so special. You're so special. These joints are not so special. They operate just like your hips and your knees and your elbows. They operate under the same circumstances. There's muscles attached. There's ligaments. There's tendons. There's nerves. There's the autonomic nervous system that goes on, and then there's the nervous system that is voluntary, or voluntary nervous system. But the nervous system that creates the forearm problems and associated pain and discomfort around, especially the forearm, with lateral epicondylitis is the autonomic nervous system. Obviously, you all know that's the nervous system we actually don't have a whole lot of control over, although your emotions, depending on how you monitor your emotions, can monitor the autonomic nervous system. You can bring your heart rate up by worrying if you want to. Good example. But for the most part, your heart beats and your lungs expand and your gastrointestinal systems work through signals given from the brainstem, lower brain. This is higher brain. Lower brain is in the brain stem. From that brain stem throughout the body. So again, in the case of lateral epicondylitis, because of overuse of this elbow, an excessive extension and contraction. I mean, these muscles contract. All muscles contract, whether they're extensors or flexors. They move because they contract. They don't move because they elongate. A muscle is, depending on its origin and insertion, it will contract, and either in the forearm, wrist, or fingers will either cause a extension or a flexion, but it's all contraction of the muscle. So these muscles, under excessive motion, tennis or other things, recurrent, repetitive motions, like someone working a machine, drill press, constantly bending the elbow, that would be another good example, can cause the muscles to contract enough where they rub against or through the lateral epicondyle, and that becomes inflamed. Well, it isn't, again, as I said, the inflammation of the epicondyle that's so critical to tennis elbow. What occurs is once it becomes inflamed, that inflammation sends a signal to the brain stem, and in the brain stem, it is modulated, and the brain stem sends back a signal, tighten up, don't move the elbow. So you can splint it, or you can voluntarily hold it up and not move it. But the point is, it gives an involuntary signal to don't move the elbow. And that is the best that the body itself, without medical assistance, drug assistance, physical therapy assistance, can do to decrease the symptoms of tennis elbow. It says tighten up, don't move the elbow. We'll see if we can help you with the symptoms and make the inflammation go down by not moving it as much or moving it at all. All right, if you understand that, you understand TMD. These joints work exactly the same way, exactly the same way. Now, I've explained this before, but hopefully now the relationship between tennis elbow, and that is what I really realized. That was what, if I discovered anything, and it wasn't a discovery. I mean, orthopedic surgeons have known about this for 50 years or more than 50 years. It's just they didn't communicate to the dentists about it. And they didn't tell the dentist in dental school that, hey, this joint is just a joint. I think that I think that orthopedic surgeons had been responsible for temporomandibular joint problems. This problem would have been solved a long time ago. Orthopedic surgeons don't want anything to do with temporomandibular. It's on the face. They don't want anything to do with the temporomandibular joint. It was left to us, the dentist and the oral maxillofacial surgeons. It just so happens that because of my broad training, and I had both dental medical degree and academic training in cell biology and anatomy, I had the information available, literally available to me to connect the dots and put it all together. So these joints work just like the elbow. But these joints become inflamed for three reasons: bruxism, acute trauma. Acute trauma is most often nowadays associated with whiplash injuries. That's what I see in practice. And functional malocclusion. Now, we've covered all three of those thoroughly as to how they create the inflammation. But once the inflammation is begun, and because you can't stop chewing and you won't stop talking, and those who do brux, and half the population bruxes, whether they know it or not, at least half the population bruxes their teeth. Grinding and clenching are both the same. They all do the same thing. Clench it or grind, it overloads the joint, creates the inflammation. Just like overloading the lateral epicondyle will create the inflammation. So once the inflammation is there, it works just like the elbow, tennis elbow. Signal goes from the temporomandibular joint to the brain stem and says, I'm inflamed. The brain stem accepts the signal, modulates the signal, and sends back an autonomic signal. I'm going to help you out. Tighten up. Don't move the joint. And it sends signals to the first signals it sends out is usually to the muscles of mastication, but not symmetrically and not always to the same muscles and not all at the same time. And the signal intensity can vary from time to time. And that is why patients who complain of facial pains don't always complain of the exact kind of facial pain, although they can. Most of the time, the facial pains jump around, and it can vary all over the board from, my headaches are right there every morning where the temporalis attaches, or right there where the masseter attaches. Or I've had a run of people talk about sinus pain. It's not sinus pain. The sinuses are clear. They got nothing wrong with their sinuses. They have facial pain in this area from muscles tightening up. Excuse me. Now, how long does this inflammation go on before the central nervous system accepts the signal that there's inflammation and sends out additional signals to try to help the problem? But in a descriptive way, you might go on for years with just headaches or jaw pain, but it might be weeks before it starts to give you neck pain. Neck pain, truly, neck pain is the second most common symptom of TMD after headaches, for sure. So many people complain of neck pains. And how do I know that? Because when you make the inflammation in the temporomandibular joint goes down, the neck pain goes down, sometimes before the headaches go away, but actually they go away in reverse orders. What I see is the headaches go away usually first, there are variations, and the neck pain is usually a second, sometimes a distant second. And then if the inflammation has not been treated, if it has not had adequate treatment to diminish, then the signal will come through the autonomic nervous system to tighten up not just the muscles of mastication, not just the neck muscles, but the entire shoulder girdle muscles. And patients will complain of shoulder pain and arm, hand, finger tingling and numbness. And the arm, hand, finger tingling and numbness, as I've said in a previous episode, is easily seen and understood by the strap muscles on the side of the neck squeezing on the brachial plexus, which causes arm, hand, finger tingling and numbness and sometimes pain. So TMD is identical in its pathophysiology to tennis elbow, strange as that may be. It is strange. And some days I wish the orthopedic surgeons had grabbed a hold of this early on, because I think they would have solved the TMD dilemma long before we have. I recently, and getting into some of these other things, and I pretty much made the point here, but I just want to, there's another part to today's episode I thought about covering, and I probably will. I got a couple extra minutes. And that is the understanding of this problem. It is so poorly understood. I watched recently, within the past 10 days, I watched an episode on a well-known podcast of a developer of a intraoral device. It's going to go unnamed, well-known intraoral device that is promoted for the treatment of TMD. And he was asked by the moderator several times over a period of an hour in a couple different ways as to, how did it work? Now, it was described in detail with lengthy anatomical, neurological nomenclature. But after being asked, and I think I counted at least 3 separate times, where the interviewer really wanted to know, well, how does it work? And the originator of the device itself basically just threw out a bunch of word salad and didn't answer the question. this is just, again, I'm not trying to, this is not intended to be critical. That's why I'm not going to name anybody, but it is an indicator of the total misunderstanding of how you decide or come across a solution to a problem. I mean, and in addition, this particular device is continues to be promoted as the solution to migraine headaches. And that's another point about this that I want to make. The studies on migraines admit they do not know what causes migraines. And this particular individual, well-meaning, and has some, I can say some good things about him and his device. But the device is promoted to treat migraines. Well, if you don't know what causes migraines, how can you treat it? Because you're not treating the cause. Who knows what you're doing? I know what it's all about. I won't go into that. But you're not treating the cause, because the cause of migraines is unknown, admittedly. We know what causes bad headaches when the temporomandibular joints are inflamed. I just explained it to you. That causes bad headaches. The muscles get tight, they pull on the bone, nociceptors stimulate pain. Temporalis, best example. So many people, it hurts right there. They literally go literally at the curve, right there every morning, doc. Well, that is the insertion of the temporalis muscles. I had a patient Monday. She pointed directly to the insertion of the trapezius in the back of the neck. So it's really a little knowledge of the anatomy and the pathophysiology and the neuroanatomy and the autonomic nervous system explains the whole thing. I think I've been emphatic enough for today. And I really hope that this actually, opens a few eyes. I do these episodes, I've stated before, really for documentation. Rather than trying to go to paper war, and we do have a study, that's obvious. I mean, we have a really good study proving everything that I discuss here, but to go through a paper war with my compatriots about the nuances of what I teach and what I discuss, I don't have time to do that and put it in multiple journals. Although eventually we'll get there, and we're going to do a study. The next study we do, one way or another, is going to be a study on migraine headaches and what percentage of people who have been diagnosed with migraine headaches actually have migraines, or what percentage of those patients, those headaches resolve by resolving the inflammation within the joints. That's an easy study to do. Probably with 100 patients or less, you can statistically prove that. And what percentage of patients don't have migraines, have TMD headaches. A little far afield for today, but I wanted to make that point about knowing exactly what causes it. If you don't know the cause, you can't actually treat the problem. So, and that applies to actually several things in medicine. Several issues in medicine are being danced around because they really don't know what the cause is. So they kind of throw mud at the wall and see what sticks. All right, enough for today. I hope I made my point. I hope I've generated some controversy. That's okay. If you'd like to comment, if you'd like to criticize, I can be reached at tony@tmjservices.net. My director of marketing and education, our company director, is Naomi at tmjservices.net. The company website is www.tmjservices.net for those of you who would like to expand your practice, or just to actually get some traction and actually solve the problem of TMD for your patients in your practice. Although we'd like you to expand beyond your own patients, because there are millions of women every morning who wake up with headaches and think they have migraines. or they have ringing fullness dizziness and the ENT doctors have no solution for that, or they have neck pain and they've been to multiple neurologists and orthopedic surgeons and they don't get relief, even with surgery. This happens. We see it all the time. So those of you who would like to jump on the bandwagon and help with this problem, I encourage you to join our network of doctors and become licensed to use the Urbanic device and protocol. And I hope the explanation I gave for you today stimulates your knowledge of this problem and stimulates your interest in actually solving it for people who really need it, who really, really need it. So for today, I look forward to our next episode in a week. I am Tony Urbanic, and this is TMD Demystified.